But one of the things that we harped on, or at least I think I was on on some Zoom, some OTA Zoom, and they were talking about nailing and proximal femur nailing and making sure that you have good images is because if you get an AP, for example, and it's too flex versus too extended, if it's too extended, the next to the greater trochanter may look a little bit more shallower versus if it's too flexed, it may look a little bit more deep. And just making sure that you have a good AP to start to x-ray off with, making sure you have your 10 to 20 degrees of internal rotation to offset that aneurysm. For you, looking at a lateral, what are some pearls that you have as far as getting a good lateral, and what do you look at when you're saying, okay, that's a good lateral of the hip?
Sure. I think really it's a tough thing to do, and just takes time and repetition to get better at it. I think one of the hardest things is distinguishing what is the shadow of the greater trochanter and what is the shadow of the femoral neck, and you've got them really nicely outlined here. And that's something that I try to really go over with the residents when we're fixing these fractures. So I try to take the time. Oftentimes, you can see the alignment of the fracture, the cortical alignment, best at the shadow of the trochanter. And I find it's especially in the anterior part of the trochanter that you can really see. Yeah, exactly.
Okay.
And so the greater trochanter is a really big structure. It's really wide anterior to posterior. It's much wider than the femoral neck. And so sometimes you tend to ignore the femoral neck when looking at alignment. So you want to see, have you restored continuity of the trochanter, anterior and posterior? And then I also find that most people, the anterior portion of the femoral neck is pretty much in line with the anterior cortex of the femur, and the posterior cortex of the femoral neck is in line with the posterior cortex of the femoral shaft. So I find that those are other cues for alignment to show that we've restored the hip to what is hopefully its neutral anatomy.
Yeah, I think that's definitely good to take part at, and definitely note when you're getting your true laterals. And I remember a rookie mistake is when we started off, like getting a lateral, just getting a straight lateral, and you're actually getting a lateral of the femur and not of the
Right.
femoral neck itself.
Right.
So making sure you may need to change your beam to make sure you're getting a lateral of the femoral neck, which may be in whatever degrees of aneurysm that that patient may have.
Exactly. And I think the ability to see the femoral head on a lateral X-ray is really crucial, because that'll help you when you're placing your screw or your blade to really make sure your tip apex distance is as good as you want it to be.
Okay. And as far as a close reduction, I know we spoke about it a little bit earlier, but just to, just for repetition is key. How do any other tips that you have as far as getting a close reduction of what you think may be a stable, intertrochanteric femur fracture?
Yeah, I think the workhorse is really what you described here. It's pulling traction, internally rotating, and then really taking the time to look at the X-ray. One thing I always do is when we set the patient up on the table, we obtain the closed reduction, we lock it in on the table. Before we drape the hip, before we prep or anything, I always bring X-ray in. I assess the quality of our reduction on AP and lateral X-rays because I want to make sure I understand the fracture, and I want to make sure I have it reduced as well as possible. So things I look at, I look at the fluoro shot, and then I look at the AP of the pelvis. Have I matched or close to matched the opposite hip? Have I restored the normal relationship of the greater trochanter and the femoral head, meaning have I not left the patient in too much varus or valgus? Assessing all those things. And if I'm not happy with the reduction, that's when I take the time to fine tune it. I say, okay, maybe we need a little more traction, a little less traction. Let me add a little internal rotation, a little external rotation. And sometimes seeing how fine maneuvers impact how your X-ray looks is very valuable. So I think time spent on obtaining and looking at the closed reduction is really valuable because it's not something you want to do once you're all prepped in and the surgeons are all scrubbed in, and all of a sudden you're asking an inexperienced tech or an inexperienced rep to work your fracture table for you because they may not understand how the various levers and knobs impact your reduction. So I think doing as much of that as you can up front, it pays dividends during the surgery.
Right. And so again, just to repeat, some of the says things that you said you look at is you look at the level of the greater choke to make sure you haven't, put them in too much varus or valgus. You get an
Yep.
AP of the hip to make sure you've matched or restored that anatomy of the femoral neck. Now, do you also like look at the cortical reads on the inferior neck when you're doing
Sure.
it? Like you just pretty much take whatever, all the clues you can get for the most part.
Yeah, exactly. I think it's there's no one thing that's going to tell you the whole story. It's looking at it as a sum total of the reduction. I think looking at the troch and head relationship is valuable. Certainly, looking at the calcar, do you have offset or have you lined it up nicely? Have you restored that Gothic arch of the inferior femoral neck? It's almost like looking at a shoulder or the Shenton's line. Have
Right.
you restored that nice contour? Have you made it look like the other side? So taking all those factors into account to see if you have an adequate reduction.
Okay.